Hello everyone and welcome to Your Health, Your Choice. I am Dr. Robin Upnarayan and we are coming to you from our studios at Olera Heights in San Fernando. On tonight's program, we'll be talking about general surgery. In studio with me tonight, is Dr. Parasram Ramraj. Dr. Ramraj is a specialist medical officer attached to various medical institutes. Tonight's show has been pre-recorded in studio, so we'll no longer have the live component on tonight's show. So, Rishi, welcome to Your Health, Your Choice. Thanks for coming into the program tonight. Let's talk about a few topics in surgery there, Rishi.
Sure, good evening. Thanks for having me.
You're very welcome. Rishi, so let's get straight into it. A common complaint that we see in the clinics is varicose veins.
Right.
If you could just tell our viewers at home a little bit about varicose veins, what causes it, what symptoms they have, and how they can treat it.
Right. So varicose veins basically are just abnormally dilated veins in the legs. Now, if we think of the human body as let's say a house with a water pump, the pump being the heart, right?
Yeah.
We have the arterial system with taking blood away from the heart to the limbs.
Yeah.
When it gets to the limbs, it has to get back to the heart.
Yeah.
And that's the venous system, right?
Right.
The venous system now returns blood to the heart, so back to the pump to go out again. Now, in a house, you have a drainage system and it drains away by gravity. However, we are standing most of the time. So the venous system, the muscular action of the calves and the legs and stuff helps to return the blood to the heart. But it's also aided by a system of what we call valves within the veins, right?
Yes.
So that ensures one-way flow.
Yeah.
So the blood in the veins flow in the direction of the heart.
Yes.
Unfortunately, sometimes those valves get damaged for whatever reason: trauma, too much standing, obesity, and of course, in some cases, familial problems with the valves, genetics, right?
Yes.
You have the valves being damaged, and then the flow is in the opposite direction, right?
Okay.
The flow is in the opposite direction, and obviously, if the flow is in the opposite direction, you'll have pooling.
Yes.
Pooling of blood. The venous blood in the veins, doesn't have oxygen because it's already utilized by the tissues.
Yeah.
It doesn't have any nutrients, right? So essentially, it's not supposed to remain in the tissues. It has to come back to the heart, to the lungs to get reoxygenated.
Yeah.
So if the blood pools there in the legs because the valves are bad, you have poor oxygenation, poor healing, swelling, pain because there's no oxygen, no nutrients in the blood anymore, right? Over a long period of time, you get progressive swelling, you get discoloration in the legs, and at the worst part of it, you can get ulcerations, tissue breakdown, simply because there's the oxygenation levels are poor.
Okay.
Right?
If you could tell us, what are some of the symptoms or the early symptoms of varicose veins?
So a lot of people will just have this pain on standing, dull pain on standing, right?
Yeah.
They could see little spider veins. So initially, the spider veins, they're more cosmetic than anything else.
Yeah.
But if you allow it to progress, it becomes worse. The veins become much more dilated, and then you'll see these snaky-looking things in your leg or the
big swollen.
Right, exactly.
Veins.
Right, and then you get the edema, the swelling, the permanent swelling, and then you get blackening of the limbs.
Yeah.
And then you can get the ulcers forming, right? Yeah. In addition to that, because the veins, there's no blood flow, remember, you could have clotting occurring as well within the veins, so you could have what is known as thrombosis.
Right.
All right, clotting, simply clotting. The constant pain is another thing. Sometimes you have bleeding from the rupture of the vessels, right?
Right.
So in the early stages, you can treat it conservatively, diet, exercise, stockings, what we call gradiated compression stockings. So it's tighter at the bottom and less tight at the top, so it allows the blood to flow back, sort of mimics the physiologic effect, right? And then there are things like people now talk about what we call sclerotherapy or foam injections to coagulate, to clot off those vessels, those abnormal connections.
Those are injections into the vessels?
Yeah, those are injections. You're right. But that's in the earlier stages, right? When the vein becomes quite large, one of the potential complications is that, it's the foam and the oils and stuff that you use to coagulate it can actually get into the main system and go to the lungs and cause, problems, serious problems. So sometimes we advocate, especially for more advanced stages, we do advocate surgery for this.
Okay.
Right?
It seems like a lot of people have varicose veins, right?
Yeah, it's very common. Very, very common.
But I mean, is it a necessity that people have treatment for it in terms of doing the surgery when they are bad? Is it something that you would recommend people have done?
I would recommend, yes.
Because I mean, sometimes we see older people in the 80s and so on, they have these big varicose veins.
Yes.
You might see people, they had it for their whole life.
Right.
And they're fairly well.
Yes.
They have no major complaints.
Yes.
So how do you know when it's time? How would somebody sitting at home know when it's time to listen, I need to see a surgeon to have this removed? Or what is that decision made by the surgeon, by the patient?
Right. So generally, if it's not bothering the patient, you wouldn't do anything, right?
Okay.
But obviously, that patient is not going to come to your office.
Exactly.
Right.
Yeah.
So,
but they might be curious as to what is this? What is this, and
what can I do?
Yeah.
Yeah. So oftentimes the asymptomatic patients are worried about the cosmetic aspect of
Correct.
it.
Yeah.
Right. So yes, you can do endovenous ablation with laser. You can do injection sclerotherapy and so on. Right.
Right.
However, when you get to what we call severe reflux at the saphenofemoral junction. That's where the deep venous system meets the superficial venous system, the ones that dilate. If that is very large, most people would advocate a surgical type approach.
Okay.
All right. The other thing that people come for oftentimes is the pain.
Pain.
Yeah, and obviously the ulceration, if it becomes ulcerated, or if there's bleeding, if the varicosities have ruptured, those are indications for surgery.
Okay, so we might have a few people, patients who have varicose vein ulcers.
Right.
It's quite common in our surgical ward to see patients with varicose vein ulcers.
Yes.
How do you treat that as a surgeon, or how would you advise the patient to treat it?
Right. So before you actually go into treatment, you need to kind of investigate what is causing it, right?
Right.
We know that varicose veins are because there's abnormalities in the veins and the valves are basically gone, right?
Yeah.
But one of the things that we need to know is where. So you have a deep system where of veins that return blood from the deeper tissues.
Yes.
And a superficial system that returns blood from the more superficial tissues. There are connections. There are multiple connections. The main one being at where the superficial vein, the saphenous vein, joins the femoral vein to go deep into the body, right?
Yes.
Right up in the groin here. But there are multiple connections at points throughout the legs.
Yes.
So one of the things that we need to do is to assess whether it's only one point that the valves have gone bad, or whether the valves are actually bad in multiple places.
Okay.
So ultrasound first.
Right.
Now, if we know we have what is known as perforator incompetence, where the deep system connects to the superficial system, then those will also need to be addressed surgically, right?
Okay.
Now, not everybody is fit enough. As you said, if the 80-year-old guy comes, he has had 5 heart attacks and,
he's
can't
not
really,
fit for surgery.
Right. The ulcers, there are special dressings that we multi-layer dressings called an Unna-Boot that you can use to kind of help with the healing. It's hard to, when patient has an ulcer, to use the graduated compression stocking. But you can use pneumatic devices to help with the blood flow as well. And of course, at the end, and of course, the definitive treatment, if the patient is fit for surgery, is some form of surgical intervention, right?
Okay.
Depending on what is available, the skills of the surgeon, and the characteristics of the blood vessels.
Do the varicose vein ulcers heal without surgery?
Usually not. Usually not.
Okay.
There are instances where they can, if you kind of, stay off the feet, keep the legs elevated, put the underboot on, and so on. But it has to be the right blend of circumstances.
All right. You mentioned that sometimes the varicose vein could rupture.
Yes.
Why does that happen? Is it because it ruptures spontaneously if somebody get hit, or why does it rupture?
Right. So as the vessels dilate, it's just like a balloon, right?
Yeah.
So our veins were only meant to hold so much, blood, right?
Yeah.
And as balloons go, the bigger it gets, the thinner the wall of the container is, right?
Yes.
So any minor trauma can cause it, or it can spontaneously rupture.
Okay. And that's a lot of heavy bleeding, I assume.
Excuse me.
Yeah.
You do get significant bleeding. If that happens to you, put your leg up and put some pressure on it and get to the hospital.
Okay.
All right? Yeah. You'll need immediate intervention.
Intervention.
Yeah.
And what do they do in the hospital for the bleeding vein?
Essentially, depending on how much blood is lost, patient may need some resuscitation.
Okay.
We will stop the bleeding either by suturing or putting a compression or something on it.
All right.
And then later on, it will have to be definitively addressed.
All right. So I just want to wrap up this part about varicose veins, but
yes.
I think the take-home message is that varicose veins is not necessarily a regressive syndrome. It's something that is progressive.
Yes, it does.
I think you're saying that people sometimes are asymptomatic and have no problems, but then there are people who have problems with their veins, and those problems might lead to a progression of the illness, and those patients, the ultimate treatment would be surgery.
Yes.
For significant disease. Those people with mild disease and just want a cosmetic fix, there are fixes available for that. And therefore, I think that's why you're trying to say that eventually most people with varicose veins will have to have surgery done.
Yes.
And then I suppose the major complications of what you explained to us is the ulcers, which are slow to heal.
Yes.
And then if it ruptures, it bleeds heavily.
Right.
So somebody with varicose veins might want to have the surgery done to avoid those two possible complications.
Yes.
Rishi, thanks for that. I just want to go to another common topic, kind of related, because you can't talk about varicose veins, and then people also suffer from hemorrhoids.
Right.
And they tend to put the two together.
Yes.
Maybe wrongly so. But can you tell us exactly what is hemorrhoids and what symptoms patients get with hemorrhoids, and what's the treatments available to patients with hemorrhoids?
Right. So hemorrhoids basically are dilated blood vessels around the anus, around your bottom, right?
Yeah.
Hemorrhoidal cushions.
Dilated venous.
Initially,
are they veins?
They're not actually veins.
Okay.
Right. So there are feeding vessels. From the arterial system that comes into a plexus.
In the anal area, rectal area.
Yes, and you call them hemorrhoidal cushions, and they're present in everybody.
Right.
They're not pathological in everybody.
Right.
But what happens is the hemorrhoidal cushions are those little areas around the anus that kind of help you sense whether, hey, this is gas, or hey, this is right, this is stool, right?
Yeah.
So once you strain, because there's arterial feed, so blood goes into it all the time.
Yes.
And it drains into the veins.
Yeah.
But it's a complex. It's like a ball of little vessels.
Yeah.
That's sort of supplied by an artery, but is dilated in a more venous nature of veins,
right.
and then it drains away.
Okay.
Right. So initially, in the old days, we used to think hemorrhoids were purely venous.
Yeah.
That has actually been shown not to be true.
Okay.
The current thinking is is that, again, the old thinking is that we used to have 3 hemorrhoidal cushions, and if you were to take a clock, look at the anus like as if you were looking at a clock, they would say, well, the hemorrhoidal cushions would be at 3, 7, and 11.
Yeah.
Right? As we've developed more invasive and more sensitive methods of examining blood flow, it was noted that patients who had hemorrhoidectomy sometimes got recurrences.
Yes.
And so the investigations showed that there were also blood vessels feeding arteries coming in at not only 3, 7, and 11, but 1, 5, 9, and so on, right?
Yeah.
And then as we got more and more technology, we realized, hey, it's at every point in the clock's little arterial vessels, right?
Right.
Now, when you have hemorrhoids, right? When you have hemorrhoids and you sort of have surgery for them, and hemorrhoids, there's a multiple approaches that you can use for hemorrhoids. From the very old, what we call surgical excision, where you go in with a blade and you take it out and you tie it off with sutures and stuff.
Yeah.
To now where we can use electrosurgical techniques without sutures, without blades, and you basically cut it off, but with better technology.
Yeah.
And then there are those like that we can use rubber bands first, so no cutting at all.
Yeah.
And then there are those that we use the technology to identify the blood vessel and to either tie off the blood vessel with a special stitch, or even using a laser and kind of coagulating it, right?
Okay.
Some of the methods, like the laser coagulation and so on, are much less painful. However, their recurrence rates are far higher. So, positives and negatives, and lots of ways.
Does the patient have to be under general anesthetic for these treatments?
They don't necessarily have to be on general anesthetic, but it can be done on the spinal as well, because once you do a spinal, that area will be anesthetized.
I understand.
The drawback to doing it with spinal is that sometimes they do have venous dilatation when you do spinals.
Okay.
So
it could bleed.
Bleeding can be a little bit more. But I mean, either way, it's relatively easy to manage.
So that's a little bit on the far end of the spectrum, right?
Yeah.
So a patient who just presents, how would a patient know that they have hemorrhoids?
Right.
And what treatment is there before surgery?
Right. So surgery is the end game. Actually, we don't really want to have to do surgery on you when you have hemorrhoids, because it's a sensitive area and it can be quite sore after surgery.
So just had to stick a pin in it.
Yeah.
We're well over our commercial break time, so we're just going to take a quick commercial break and we'll come back in 2 minutes.
No
All right,
problem.
guys, so I'm here with Dr. Rishi Ramraj. We're taking a quick commercial break. I'll be back in 2 minutes.
Hi everyone, I'm Stacy from Stacy's Kitchen. Check out our new episodes, Season 3 of Stacy's Kitchen at our new time, 5:30 p.m. on Mondays and Wednesdays, right here on ACTN The Voice. I will be whipping you up some flavorful and appetizing dishes. As they say, good food makes a good mood. So guys, stay tuned for this culinary explosion right here on Stacy's Kitchen.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. Your Health, Your Choice. You're here with Dr. Rishi Ramraj, and we're talking about some topics in general surgery. Rishi, sorry about that. I interrupted you just before the break.
Yeah.
How would someone know that they have hemorrhoids? And you described the end result of surgery, the different surgical processes, but there must have been a pathway before that.
Yes.
So what happens? What causes it? What causes hemorrhoids? And how would somebody know they have hemorrhoids? And what non-surgical treatment is there?
Right. So when we were speaking earlier, we spoke about straining.
Yes.
Straining at stool, right? Causing dilation of the hemorrhoidal plexuses around the anus, right?
Yeah.
Now, straining essentially means that you have poor bowel habit, or really, poor pelvic floor function, right?
Right.
But most usually it's bad diet. We don't eat enough fruits and vegetables. We don't take enough dietary fiber. We don't drink enough water because for whatever reason everybody works.
Yeah.
You drink some coffee. You rush off to work.
Yeah.
You eat fast food.
Yeah.
You don't have time to go to the washroom.
Yes.
So it's basically this lack of self-care and attention to the bowel habit, right? So our primary goal is to utilize the dietary and lifestyle changes, right?
Right.
So basically what you want to do is to increase dietary fiber, fresh fruits and vegetables, increase your water intake. We tell people 2 liters a day, but generally 2 liters is really hard to drink.
Yeah.
But if you can do it, that's really good. I know for sure I can't make 2 liters, but we do advise that 2 liters. Fiber supplements like Metamucil, which is a psyllium-based fiber, and that's recommended by the American College for Colon and Rectal Surgeons.
Right.
30 grams a day, soluble fiber. And don't sit on the toilet too long. Don't go there with your newspaper and your phone and spend a half an hour.
I think that's a big thing nowadays. People get involved. That's reading or being on social media. So I suppose you use the washroom when you have to use the washroom.
Yes.
And if you don't need to use the washroom, if you don't need to use the toilet, you don't hang around.
Right. Recognize the trigger and go. And in addition to hemorrhoids, the poor bowel habit is also associated with the fistulas and the fissures, perianal abscesses, things like that, right?
Yeah.
Straining at stool. So that changing the diet solves a whole lot of those problems.
Yeah, and I suppose in Trinidad we have a lot of like fast food and processed food. We eat a lot of that.
Yes.
That contributes to constipation and could also lead to hemorrhoids as well.
Yes, because there's no fiber. There's no fiber in
processed
in
food.
the fried chicken or the burger. There's no fiber at all. So it's all starches and highly processed meats and fats.
Right. So how would someone recognize that they have a hemorrhoid?
Well, initially, you start with like pruritus, like scratching, itchiness around the anus. You might have some bleeding or dripping into the bowl, and usually it's bright red and painless for hemorrhoids, right?
Right.
Other than that, as the disease progresses and gets worse and worse, you can see the cushions starting to prolapse as they get bigger.
Yeah.
Sometimes they prolapse and they come out and they go back in for themselves.
Yeah.
And in the worst stage, they come out and they stay out, and you as a patient, you have to push it back in.
Right. And then sometimes it becomes very painful as well.
Sometimes if it becomes thrombosed, it becomes very painful. So that's where the blood clots off in it.
Right.
And that actually does require surgical intervention. That is not one for conservative margin. Once you have acute pain with the hemorrhoids, you need surgery. You need to evacuate the hematoma.
How about the creams and so on that are on the market? Do they help?
They help in a little way in terms of symptomatic relief, but they do not address the underlying issue, which is the bowel habit, which is the straining
and the diet.
Yeah.
Okay.
They do help a little. Some of them more than others.
Yeah.
And
so if a patient, if someone changes their habits, proper eating habits, eating a lot of fiber, drinking a lot of water, not hanging around in the washroom when they don't need to, but they try to turn to a more fiber-rich, natural way of eating, right?
Yes.
Those patients sometimes don't need surgery, is what you're saying?
Yes, you can,
They can
avoid surgery. Yes, it's one of the things where changing your lifestyle can avoid surgery. Alcohol,
Right. Yeah.
smoking,
Yeah.
pepper,
Yeah.
these can be triggers as well.
Right.
And so if you can get your patient to avoid or ease upon those things,
Yeah.
it helps with the hemorrhoids, but it also helps.
Everything else.
Yes.
All right. Just moving away from that now again.
Yeah.
A very common surgical event or emergency that everyone talks about is the appendectomy. Can you tell us how would someone realize if they have appendicitis?
Right.
Take us through that, because appendicitis is probably one of the most common surgical emergencies in the community.
Yes.
And sometimes we still have people not recognizing that they have appendicitis, or some people not sure what it is.
Yes.
But it is something that if you educate the audience at home,
Right.
they might be able to help themselves or a relative to get into the emergency room quicker than they should, and
Right.
therefore prevent complications of appendicitis.
Right.
I still hear stories as a GP of patients coming and saying, oh, my uncle or my grandfather or my father, they died from appendicitis.
Yes.
You know what I mean?
Yes.
Or it was ruptured and they had
Yes.
complications and had big surgeries.
Right.
Nowadays it's less common.
Yes.
And I'm hoping for the future generation that we don't hear about that at all, as best
Right.
as possible.
Right.
So could you just educate us a little bit about appendicitis?
Right. So the appendix basically, guys, it's a little tube. It could be about the size of your index finger. It's attached to the beginning of the large bowel, where the small bowel goes into the large bowel. So it's a blind ending tube, and sometimes this tube gets blocked, and because it's got, there's a lot of bacteria and stuff in it, can get infected and swollen, right? Now normally what happens is the pain starts around your navel, and it's kind of a crampy pain around the navel. It's not that bad.
Yeah.
But over the course of a few hours to maybe a day, it moves down into the right lower quadrant here, just by your flank here.
Yeah.
And it becomes constant and severely painful.
Right.
There may be vomiting, fever, diarrhea,
Right.
and general unwellness. You probably would have lost your appetite as well. You don't have to have all of those things or any of those things, except for the main thing is the right lower, the pain in the right flank here, right? So once you have that and that pain does not go away, well, it's not Nara, it's not Boucher, it's not anything else. It's your appendix, right? And as Doc alluded to a minute ago, if you leave it alone, it can rupture and can cause severe problems. Bad problems inside the abdomen, inside the belly, and even up to and including death from sepsis from the infection. Right? So getting it out early is your best bet to avoid any of the complications. Now, of late, maybe for the past 10, 15 years, a number of studies have been going around showing that antibiotics can be useful without an operation. There are certain special criteria that you have to fulfill before you do that. That's one. And two, there's a high risk also of recurrence, almost about 40% within a year that you'll actually get it back, and you may need surgery as well.
Very common question that everyone will ask: what is the purpose of the appendix? Why God put it there? Why are you taking it out?
Well,
if it's not giving me problems, because sometimes just randomly, if a surgeon is operating on someone, they might take the appendix out. And coincidentally at the same time as surgery.
Yes, sometimes the appendix may be taken out.
Any function for the appendix? Have you elucidated any function for the appendix?
So I always tell my patients it's there so that surgeons can make a living. But there are some lymphatic tissues and stuff in it, so it can contribute to immune function as well, but not essential to immune function. Just contributes. There's no deleterious effect to us. Yes, removing it. All right.
What happens? How long if someone starts getting pain in the appendix? Really?
Yeah.
I mean, on this side, which is the right side.
Right side, yeah.
How long before? What's the time gap before they end up having being in theater, getting surgery done?
So once a diagnosis is made, you should have surgery. As I said, there are a few occasions with special criteria that must be met, that where you can use conservative management, meaning antibiotics and so on.
Right.
But by and far, the vast majority, and still the standard of care, is removal of the appendix.
All right. So what I get from you there, Rishi, is that, hey, once you're at home and you're getting a pain on your right flank, right iliac fossa, we would call it in medicine.
Yes.
But it's the right side lower down. You're getting a constant pain there that didn't just go away after 10 minutes, but it's constantly hurting you.
Yes.
Find your way to medical attention.
Yes, please.
Yeah. If it's getting worse, well, then you definitely know that something is up, and that's usually a clinical diagnosis.
Yeah. Don't ignore right-sided pain. Nothing good.
Right-sided.
Yes.
Yeah.
Nothing good. Comes up.
Something is happening.
Yes, something is happening
on the right side.
Yeah.
That's great. Rishi, I just want to move on to a different topic again. Something really big and important is colon cancer, right?
Right.
When should someone get screened for colon cancer, right? And also, what symptoms would someone have, an average person at home, that would make them think, hey, I need to go into the doctor to be screened for colon cancer?
Right. All right.
Or something is not right here, and I need to see a doctor who might check me for colon cancer.
Right. So this is a humongous topic. Right? This is a humongous topic. So the first question you ask is, who should get screened?
Yeah.
Right. So about 2 or 3 years ago, the recommendations were changed from 50 to have colonoscopy to age 45.
Oh, wow.
So every person over 45 now, that's U.S. Preventive Services Task Force recommendations. Every person over 45 should be screened via colonoscopy, or at the very least screening a sigmoid and a fecal occult blood test.
Okay.
Right?
Everybody over the age of 45.
Everybody over the age of 45.
Now, that's good information.
Yes.
Because I think they understand, a lot of people still think they have to be over 55, they have to be older, over 50, before it's everybody over the age of 45.
Everybody over the age of 45. Now, the good thing is, if you have a normal colonoscopy, you don't have to do it back for 10 years.
Okay.
Right? And also, the other good thing is, if you have an abnormal colonoscopy, you've caught it early.
Right.
Right? And we have seen in Trinidad here, we are seeing younger and younger people getting colon cancer.
Okay. So the screening for colon cancer is a colonoscopy?
It's a colonoscopy, or you could, if you can't do a colonoscopy, you could do a sigmoidoscopy, flexible sigmoidoscopy, and a fecal immunologic blood test, or
a fecal occult blood test.
Yeah.
So is it all three, or can somebody just do a fecal occult blood test, and if it's negative, that's a screening, that's a way of less likely to be colon cancer?
Yeah, in a low-risk person, but I would advocate also
get a colonoscopy,
adding at the very least the sigmoid, the flexible sigmoidoscopy. Because the sigmoidoscopy takes you to the left side of the colon, and the majority of tumors are found on the left side. The full colonoscopy, of course, is the best thing, and that is the gold standard. That is what is recommended.
All right. So, how somebody who's not in that age group, or somebody who might not have had a colonoscopy done, and somebody might say, well, I choose not to have it done.
Right.
Well, how would they know what symptoms would make someone say, look, I need to go for a colonoscopy?
Right.
Somebody's 46 years old.
Right.
What symptoms, or what would make them think that something needs to be done?
Sure. So there's. The colon is quite large. It starts on the right side of the belly, and it goes all the way around to the left side, like on the outside here, and then comes back towards the back and goes to the rectum, right? Now, the right side of the colon is a little bit wider in size
Yeah.
than the left side, right?
Yeah.
So for right-sided colon tumors,
Yeah.
you may get what we call constitutional symptoms before any colonic type symptoms.
Right.
Right? So it may be bleeding, you might feel weak, you get anemia, and nobody knows why.
Okay.
And because the right side is larger, you could actually feel a mass sometimes
Right.
on the right side before anything else, right?
Okay.
Usually, it'll be associated with weight loss, unplanned weight loss and general feelings of malaise, right?
Right.
Left-sided tumors, they could be, because it's narrower, they could present more with obstructive type symptoms. So you can't pass stool anymore, and your abdomen becomes distended, and that, of course, that leads to emergency surgery,
Okay.
which you don't really want,
Yeah, of
because
course.
then the outcomes are poor, right?
Yeah.
Or you could have bleeding, so you could have bleeding, so frank bleeding
Yeah.
from that side, but it doesn't necessarily have to happen like that. On the left side also, if it's not obstructed, sometimes you'll find that your stool
Yeah.
becomes narrower and narrower, so we call it pencil thin stool.
Right.
So you're looking for a change in the bowel habit with pencil thin stool, and sometimes these tumors, they produce a lot of mucus, so you might find mucus in addition to maybe some blood from the back passage.
All right.
Right.
So what I get here from you is anybody who has weight loss,
Yes.
anemia, which is anemia is a low blood count.
Low blood count,
But the person
yeah.
will feel tired and weak.
Yes.
And anybody who's suffering from constipation with a change in his stool, the stool might become pencil thin as what you
Yes.
described it, or might have mucus with it.
Yes.
And if they see in blood,
Yes.
well, these people need to be screened for colon cancer.
Yes, absolutely.
In the past, we always used to think that colon cancer was something for older people. But you're
Yes.
saying in Trinidad and Tobago, we've seen a lot of cases with younger and younger people having
Yes,
colon cancer.
we are seeing younger and younger people
Yeah.
every year. Yeah. I had a patient who was 20-something years old recently.
Right.
27, I think, and for the past 10 years, we've been seeing patients in their 20s.
Right.
So we can say that yes, maybe the age is getting, we're getting younger here. I don't know why, if it's dietary, genetic, environmental, I really can't say. But we do need to be aware, especially if any of these alarm symptoms that we mentioned earlier occur, you do need to get yourself checked.
All right.
And the other thing is, if you do have a strong family history of colon cancer, you can present earlier as well. So you should be screened. You should have genetic and familial screening, and must have colonoscopies early. There are certain types like what we call FAP, familial adenomatosis polyposis syndrome, or HNPCC, which is hereditary non-polyposis coli, cancer of the colon. Yeah, those kinds of things. You need to get your investigated. You need to get your genetic testing done, and you need to get early colonoscopy and
So
intervention.
once a relative has colon cancer, go in to see a doctor because you need to be screened earlier than normal.
Yes, first-degree relatives, and there are a number of criteria that you can use. If you have multiple second-degree relatives,
Right.
you should also entertain that as a diagnosis. Yes.
All right. So, Rishi, we're going to take our second break now. All right, guys, so we're here with Dr. Ramraj, and we'll be back in one moment.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
You have experienced a miracle. You are healed.
What do you want from me?
Follow me. He performs miracles and seeks no credit? Who did this?
I don't know his name. His time for man to know has not yet come.
Hi guys, welcome back. We're here with Dr. Rishi Ramraj, and we're talking about various topics in surgery that he comes across on a daily basis. Rishi, welcome back again. Pancreatic cancer.
Yeah.
It's something very very common that we hear about. I suppose it's common in the news because we hear about it because people die from it.
Yes.
Tell us a little bit about pancreatic cancer. Why is it such a high mortality rate?
Well,
And what can we do to diagnose it earlier if we have this problem to avoid people from having such a high mortality rate?
right.
Am I correct in saying that it has a high mortality rate?
So it does have a high mortality rate, and the reason why it has a high mortality rate is that when you find it, it's pretty late, right?
Yeah.
So the pancreas is an organ that is really hidden deep inside the body,
Yeah.
behind many of the things,
Yeah.
your stomach, your gallbladder, liver, all of those things, duodenum
Yeah.
and stuff. It's way down there, and it's very close to very big major blood vessels, right?
Yeah.
So it's not something that, okay, when we spoke about colon cancer, you put your hand on your belly,
Yeah.
you feel a little lump.
Yeah.
Generally, you won't feel any masses in the abdomen.
Yeah.
And oftentimes, one of the first signs is this weight loss, and the patient becomes jaundiced.
Yeah.
And that's at that point in time, they've already blocked off their bile duct. They
Yeah.
might have already blocked off some of the major blood vessels.
From the cancer.
Yes.
Okay.
And at that point in time, it becomes very, very hard, difficult, if not impossible, to resect at that stage, right?
Okay, so you're saying that before sometimes in pancreatic cancer, the patient doesn't recognize any changes until it's
Right.
very advanced.
Yes.
But is there any pain or early weight loss associated with pancreatic cancer that could clue people in to search for it?
So pain, yes. Pain is one. But by the time you have pain, it means that
Something being blocked off.
yes, it means that the nervous plexus around it has been invaded, right?
Right.
So your best bet is if you have a tumor that's very close to the bile duct, that blocks the bile duct very early,
Yeah.
and that triggers the investigations.
Okay.
Right?
Okay.
So jaundice, you need to be investigated immediately.
I understand.
But really and truly, there's no screening tool. You
Yeah,
know,
for
there
pancreatic cancer.
are again familial cases,
Yeah.
and patients who have high risk factors, chronic pancreatitis from alcohol, for example, or cystic fibrosis, any inflammatory condition of the pancreas. These are people who may at some point, want to get evaluated, but in terms of routine screening and stuff, for pancreatic cancer, really, you really don't have that.
Okay, you just touched on two possible risk factors there for pancreatic cancer.
Yeah.
What are the other risk factors for pancreatic cancer? Or those are the only two really big?
No. So environmentally, alcohol
And alcohol.
and the consumption of straight alcohol, so pure alcohols. That's esophageal as well as pancreatic. A lot of alcohol. Smoking also is a risk factor. There are certain exposures to environmental factors, chemicals and things that can cause that. Genetic mutations can also cause the not the pancreatitis, but the pancreatic cancer.
Okay.
All right.
All right. So what I get from you is it's not really, it's kind of bleak there because you say
Yeah,
that
it
it's
is
very hard
bleak.
to diagnose it.
Yes.
Because people might have no symptoms, or when they have symptoms, might be a bit late.
Yes.
And therefore, that's where the cancer is really taken root. So, what is the treatment when somebody is diagnosed with cancer, pancreatic cancer?
So the best option that you have
Yeah.
is if it's a tumor in the head of the pancreas,
Yeah.
and you identify it early enough
Yeah.
that it hasn't invaded blood vessels and stuff.
Yeah.
And you can do a very, very complicated operation
Yeah.
called a Whipple's operation.
Yeah.
to try and afford a cure
Right.
for that, right?
Right.
So it involves taking out a lot of the pancreas, a lot of the surrounding
Yeah.
organs, or stomach and small bowel and so on.
Yeah.
And that is a possibility. If you get it early enough, you can have curative surgery.
Yeah. And where's the pain usually associated when someone gets pancreatitis or pancreatic cancer? Where do they normally get the
It's
pain?
usually epigastric.
Right, in the
Yeah,
center there.
usually, yes.
Higher up. Yeah. But it's not all bleak because not everyone dies from pancreatic
Not everyone
cancer.
dies from it, yes.
And sometimes you do pick them up.
Yes.
I picked up a patient with pancreatic cancer very early.
Yeah.
And what I think allowed me to pick it up, and the patient is still alive and well and
Yes.
about to travel and go on a holiday and go to university abroad,
Yeah.
is that she was getting epigastric pain.
Yes.
The person was getting epigastric pain.
Yes.
Pain here. And yes, it's nice. It's natural to think about gas and acid reflux and all
Yes.
that. But at some point in time, if somebody's getting pain there and it's not settling down, they should do an
Yes.
investigation.
Yes.
An ultrasound or a CT scan or
Yes,
something.
yes.
And that kind of led to the diagnosis.
Yes.
So my point being to the people in the public is, if you have a pain or you have something affecting you and it's not getting better, don't delay and hang around and wait. Go to your doctor and ask for an investigation to have it looked at.
I think that's something that we really, really need to.
Because if the tablet not working,
yes,
and that's it. But I mean, obviously you didn't have a good relationship with your doctor as well,
Yeah.
because I mean, she called me and said, "Robin, look, the tablet not settling down."
Yeah.
I said, "All right, find yourself back in. We need to talk and we need to look for something."
Right.
So I suppose you have to not sit back and wait if you're not feeling well. You have to be
Yeah.
very proactive for your own health.
Yeah.
And that's how you catch things early. And that's how you could probably win with something like pancreatic cancer and some other hard to diagnose cancers. You get my
Yes.
point when I talk about Rishi?
Yes.
Yeah.
Don't ignore
Your
symptoms.
Yeah.
Yes.
Yeah.
Get investigated. It may be nothing, but
Yeah.
it could save your life.
Exactly.
Yeah.
So moving away from that altogether,
Yep.
I really given you a whole gauntlet of now different points to discuss.
Yes.
Hernias, you're only hearing about hernias. People get hernias, workmen, people who lift in stuff, they get a hernia. Women get hernias as well.
Yes.
But it's a lot of misunderstanding of what is a hernia.
Yeah.
Right? And there's a lot of confusion.
Right.
Can you explain to us what is a hernia?
So basically, for us, a hernia is an abnormal protrusion of a part of your whatever. So in your bowel, basically in your
Yeah.
abdomen,
Yeah.
right? There are a couple of places where it can occur naturally, like in the groin here in men.
Yeah.
You'll find that swelling, as you said, a lot of increase in intra-abdominal pressure.
Yeah.
So heavy lifting, coughing, straining at stool also gives you hemorrhoids. But you can get hernias from it, right?
Right.
So the problem with hernias is that although they're there, a lot of the times they're not painful or anything.
So it just looks like a ball coming out from the
Yes, it
area.
looks like a ball either coming out from by your navel or by your groin here, just
Right.
above just by the pubis here,
Right.
on both sides,
Right.
left and right, right? And those are the commonest locations. There are multiple other locations, but these are the commonest ones that you will find.
Right.
And the problem with it is that most of the time it's not painful,
Yes.
but unfortunately, they can present with complications like trapping of the bowel, and if that happens, you can get intestinal obstruction. You can get the bowel dying, which we call strangulation. All right, and those are complications which can also kill you. And therefore, we advocate, especially in the young and fit, to do early repair.
Okay.
Right?
All right. So you'll have a lot of patients hanging around for years. You'll say they have this big swelling there, and
Yeah.
that never happened to them.
Right.
Right? And so is it that all these patients should eventually have it repaired? Because some people think that they don't need to get it repaired unless they have actual pain.
Right.
Well, what do you say to that?
So there's a lot of studies showing that in the older patient, you can do something known as watchful waiting, right?
Right.
But in the patient who is young,
Yeah.
the chance of it presenting over their lifetime with a complication, a life-threatening complication, is high.
Of course. Makes
right?
sense.
So you repair all those in there. Anybody under 50, repair one time.
Okay.
Don't even waste time.
Right.
Right?
To prevent complications
Yes.
later on.
Anybody probably older than 65,
Yeah.
you could wait and watch and repair that as an emergency.
Right.
Unless they do, that's asymptomatic hernias, right?
Right.
The moment they become symptomatic,
Yeah.
meaning they have pain,
Yeah.
meaning they have problems passing stool,
Yeah.
meaning they have difficulties passing urine sometimes.
Yeah.
As soon as it becomes symptomatic, you need to fix it.
All right.
Yeah.
So the question that I get a lot from patients, sometimes young men in their 30s, 40s,
Yeah.
they come in as professional men or whatever. They have go to the gym, they've done a lot of straining, and they
Yeah.
suddenly develop a hernia.
Right.
And they say, Roman, I'm a busy man. How important is this, and how long does the surgeon take, and when would I be back out to work?
Right.
That's a typical question I get from people
Right.
with asymptomatic hernias.
Yes.
Can you answer that question?
Right. So hernias can be done open or laparoscopic.
Yeah.
In our country, laparoscopic is a little bit costlier,
Mm-hmm.
but less pain, faster return to work, and things like that. Even so, with the open surgery, you depending on your work, if you're an office job, you can be back to work within a week.
Okay.
Some people, highly motivated people, are back to work in a couple of days once the initial soreness is gone.
Right.
The operation itself does not take long. You can come in the morning, get it done in an hour, and go home by
All
evening.
right. What is done in the operation?
So typically, let's take one of the groin
Yeah.
hernias, right?
Yeah.
So you open up the skin,
Yeah.
and you go down into what we call the inguinal canal, which is between the layers of muscle
Yeah.
of the abdominal wall, right? Once you find the inguinal canal, the hernia sac,
Yeah.
that's the content with the bowels that have been protruding out.
Yeah.
That usually you will identify that, and you have to separate it from the associated structures. So in men, you want to preserve all the vas deferens, which takes sperm
Yeah.
from the testes.
Yeah.
You want to preserve
All the genital
the testicular
urinary
arteries
stuff.
and nerves
Yeah.
and so on. So you take so obviously it's not something that you rush through,
No.
because you need to preserve these
Yeah,
things,
yeah.
right?
Yeah.
Nevertheless, it takes usually about an hour or so, sometimes
Okay.
an hour and a half for big ones.
Right.
Once you've identified the sac,
Yeah.
if it's small enough, you can return it into the abdominal wall,
Right.
through the abdominal wall,
Yeah.
back into the abdominal cavity.
Yeah.
Or if the sac is quite large, you may have to actually remove the sac.
Okay.
All right? But at the end of the day, once that is done, once you've handled the sac, you need to repair the abdominal wall.
Right.
And that is done with a mesh.
A mesh.
Yes. So
And then you stitch it up. Oh,
yes, you can stitch it up, or in laparoscopic, we have special instruments that you just bam, 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 and done.
that's it.
Yeah.
And patient could go back out to work in a week time.
Yeah. Office jobs in a week.
Non-office job, laborer work. What kind?
Labor can go back with mesh, can go back in about 6 to 8 weeks, depending on how much they do.
Right.
But usually most of the laborers would get like a little note stating, lighter duty. So they could probably go up to about 20 pounds, but you wouldn't want more than that really until the mesh is fully embedded. And
How long does that take?
it's 8 weeks.
8 weeks.
Yeah.
All right. So then you go back to normal activities after 8 weeks.
Yeah, so you can go back to running and moving around
With
and
the
stuff
gym and so on.
within a week or two.
Okay.
Yeah, driving after 2 weeks, you can climb stairs, walk, and everything from the same day.
All right.
Yeah.
So that's going to give you a moving away from that and something a little bit less surgical and more minor surgery.
Yeah.
What is a lipoma? Because
Lipoma.
patients typically have.
Yes.
They typically come into the office and they go, Doc, I have this big swelling right here.
Right.
What is it? So you can explain what a lipoma is.
So a lipoma essentially is just a benign collection of fatty tissue that is proliferating abnormally. So we know most times when we say abnormal, everybody thinks, oh, it's bad and cancer. No, it's not. It's just a couple of fat cells behaving badly and proliferating, right?
Yeah.
So and usually it's an easy fix, meaning just you go in and put a little cut and you take it out. This is a minor procedure.
Right.
As you said, though,
Yeah.
some patients do wait
Yeah.
until, so it starts small and then
Yeah.
over the years it gets bigger and bigger.
Yeah.
And some people do wait until it's football or grapefruit size
Yeah.
before coming for attention.
Yes.
But again, I would want to say very rarely,
Yeah.
once it gets above 10 centimeters, there's
Yeah.
a very, very small, less than 1% chance of what we call malignant transformation.
Okay.
But very rare.
Very rare.
But you don't want
No.
that 10 centimeter hump on your shoulder. I
Yeah.
mean,
Yeah, so
you know.
removed.
So we get it out for more for cosmetic reasons than functional.
And most of those are removed under local anesthetic.
Most are removed under local, or it's pretty big.
All right. Rishi, we've come to the end of the show. Just like to thank you for coming in tonight.
Yes.
It's a little different format tonight, but give me more time to ask a variety of questions, a variety of topics, which is very important to the public, which they come in with and which they come
Yes.
into the clinics with and the hospitals with. And I was hoping to address those
Yes.
common illnesses
Yes.
and that they seek public health and private health care for,
Yes.
and really give them a proper explanation as to the questions that they may have.
Yes.
And I think it totally delivered that tonight,
Okay,
and I
great.
very,
Well,
very
I
much
hope
appreciate
I
it.
hope that you know, someone somewhere would have benefited and maybe save your life at some point.
I'm sure they did. I'm sure they did.
Yeah.
All right, guys. So thanks again to Dr. Rishi Ramraj. Tonight's production has been pre-recorded in studio. From next week, we'll be back out live. And I just want to wish each and every one of you a pleasant evening. Good night, everyone. Take care. God bless you all.